when your patient rolls through the door. So what are you gonna do? They call and say, we have a patient coming in with having chest pain. He's feeling syncopal, blood pressure's on the low side, heart rate's fast. He rolls through the doors. What are things you're gonna want to do to your patient right off the bat? KG, you don't have time for that yet, but you will get one in a minute. But just monitor, right? Let's just get them on the monitor. We don't need 12 lead yet, we just need, yeah, so if that's what you're talking about. Yes, okay, so monitor, leads, right? Normally they put 3 leads on. 1, 2, 3. So we put them on the monitor. Okay, what else?
Check for a pulse.
Yeah, check for a pulse, right? Or even let's get a blood pressure, right? So you've got people doing things, right? So somebody got them on the monitor. Another person is, let's do all this, right? Let's get a blood pressure and let's get a pulse ox on them, right? So this is what another person can be doing. Pulse ox and checking their blood pressure, right? It takes a minute to get them all hooked up, doesn't it? In real life, the nurses do it very fast. But us, we're not probably quite so fast. So blood pressure cuff is on, so we're gonna push that button and turn that on, get the pulse ox on them, right? So we can get vitals, right? Check for a pulse. What's their pulse feel like? Hopefully the monitor will tell us their heart rate, but you always want to check the pulse as well, right? Is it thready? Is it strong? How does that feel? It feels a little thready. You feel it, okay? And we get a blood pressure. So if you're the team leader, you're gonna have to tell your team to do those things. So you'll assign a role before the patient rolls in and you say, okay, Gracie, you're gonna put the blood pressure cuff on and the pulse ox. Corbin, you're gonna go ahead and hook him up to the monitor and let's see what his vitals are. So vitals are respiratory rate, blood pressure, heart rate, pulse oximeter, and then looking at our rhythms, right, on the monitor. So those are things we wanna get done right off the bat. Okay, if he's having chest pain, you could also ask him, what are the things that your patients get for chest pain? What has the EMS probably done? Yeah, nitro, they've probably already done that. So blood pressure was too low, probably wouldn't give him nitro. So it'd be questionable. Did they give him some already? And maybe that's why his blood pressure's low. So the question we would say, has he had any nitro? Okay, good. Because nitro does what? What group is it in your? Think of, why do you take nitro? Decreases the chest pain, right? Doesn't hurt as much by vasodilating the coronary arteries, so blood can flow better, right? So vasodilates a little bit, which also drops your blood pressure, makes you feel a little warm, gives them a bad headache, but it decreases the angina, right? Okay, so give them some nitro unless their blood pressure's too low. What else?
Oxygen.
Oxygen, if their stats less than 9, ACLS used to say 94, I think it's 92 now. So if they're a little bit low on oxygen, or they're complaining of shortness of breath, ACLS likes to say, if their pulse ox is low, put them on oxygen. If it's not, leave them. I don't really love that. If they're short of breath, yeah, let's give them a little extra oxygen. It's not gonna hurt anything, even 2 liters. So complaining of shortness of breath or low stat, yeah, throw some oxygen on. Okay, what else? So it's N and A, N and O, right? What's Mona? Morphine, what would be a qualifier for morphine? Why would we give morphine and why would we not give morphine? Right, driving chest pain, so you could give morphine for that, and it also relaxes a little bit, so it helps with the chest pain. Who wouldn't get morphine? Blood pressure. Nitro and morphine both drop your blood pressure. This patient's blood pressure already low, we don't want to be dropping them anymore, right? It relaxes everything a little bit. Okay, so morphine if blood pressure allows, and then what should they have probably already had on the ambulance if they were awake? Aspirin, right? So they probably already chewed an aspirin. If not, we'll have to chew an aspirin. You want them to do a chewable aspirin. The other ones are coated and they'll take a long time to work. They have to be dissolved in the stomach, so the chewable ones work much faster. So you want them to chew the. So the children's aspirin, it tastes way better to chew than the adult ones are. I don't even know if I could chew one of them. They taste horrible. So you like, oh. So, but yes, chew up an aspirin is what you want them to do. Okay, so. Those are questions we would ask the EMS or whoever brought them through, or if the patient just came walking into the ER, these are things we would be getting ready to have on board, right? Okay, so he's having chest pain. He says, I feel short of breath. I feel like an elephant sitting on my chest. We've got him hooked up to the monitor. We've got our meds over here is our med card. These are some of the meds that we would have. I don't think I have them all in here, but this is just kind of remind you of things that you might be wanting to do, because we have them laid out in here. So if you are calling for those meds as the team leader, we would come over here and grab them, set them on the bed. That way the person doing the documenting will kind of know what we've got out, what we've given to the patient, right? Okay, so some of the meds are in there. We've got the monitor there. We've got pulse ox, blood pressure. We have an ambu bag handy. We'll pretend like that's an oxygen flow meter up there to hook it to if we need it. And we have got a nasal cannula. So put your nasal cannula on your patient if the status is low as well, right? So as you're hooking these things up, I will give you those numbers. I'll say, okay, blood pressure is this, respiratory rate is this, stat is this, heart rate is this. Okay, and then I'll flip around the monitor and show you what the monitor shows us. And then you can figure out what category we're in and how to go down your flow chart, right? Okay, so this patient was complaining. Let's see, here's my scenario. You're in the emergency department and a man presents with chest pressure, shortness of breath, lightheadedness, and palpitations. So what are palpitations? I'm having a weird heart rate. Yeah, it feels like your heart's beating really hard. They feel like their heart's beating out of their chest is usually how we talk about it. All right. He's in acute care of the area of the emergency department. On initial assessment, he appears uncomfortable, pale, and diaphoretic. Okay, we know what diaphoretic is. They're sweating when it's not hot. Okay, carotid pulse is barely palpable. Okay, they did do, they've kind of included blood sugar checks. They should in our area because we have so many diabetic patients. But check the blood sugar while you're at it. Just prick the finger and get a blood sugar or a blood glucose level. His is 56. What's really low on blood glucose? Less than 40 is a problem. But less than 40, they're going to be in and out of consciousness. So if this is kind of in normal range. It's on the low side, but it's not terrible. Okay, and so then you got him on the monitor. To the RF monitor, which is what he has in him, which I think it must be out for some reason. And I thought, just got the monitor and changed it, now it won't change again. So we're stuck with this monitor, and all our patients are going to be in SBT. Just did all this yesterday. I just started it yesterday. What this one color? Palpation started about 30 minutes ago, so somebody who's team leader would need to be asking the family or the EMS people this history. He feels okay other than his heart, which is racing. He had about an hour of chest discomfort that worsened with exertion before the palpitations began. There's no pre-existing illness. He has his medical history of hypertension. He is a former smoker. He does take metoprolol by mouth once a day for years, and he's already taken aspirin once daily. He doesn't have any allergies. So, what would you like to do with this fellow? Did you want to get vitals? We asked for vitals, right? We've got them all hooked up. Okay. His heart rate is this 154. Blood pressure. Couldn't get a blood pressure. He is feeling kind of in and out of it. And blood pressure wasn't able to be done. Respiratory rate's 24. His SAT's 78, but it's not a good waveform. Temp, normal, temp 37 degrees. Weighs about 80 kgs and he's 64 years old. Okay, so what's your next step? Here's your patient. This is what he looks like. He doesn't feel good. He's diaphoretic and pale. Can't get a blood pressure on him. What's our treatment for, what is this rhythm? Tachycardia, right? VTAC. It's wide and fast, right? Really wide, it's VTAC, right? Now, is this a pulseless VTAC or VTAC with a pulse? He's got a pulse. He doesn't have a blood pressure. He's got a pulse right now, so we need to do something, right? So that gives us, comes to our branching on our tachycardia algorithm, right? He has a pulse. So we're on the adult tachycardia algorithm, adult tachy. So on the adult tachy algorithm, where do we go from here? Identify and treat underlying cause. We don't think he has an underlying cause that we know of. Assist breathing is necessary. He's breathing on his own. We got him on some oxygen. Put him on the monitor. Do a 12 lead if it's available. So we'll call for a 12 lead. They're not here yet. IV access. Did somebody start an IV? EMS already started the IV day. Okay, so you're really looking at, right off the bat, does he have these things? Hypotension. Yeah, we can't even get a blood pressure, right? Acutely altered mental status. Kind of coming in and out of it, feeling a little like he wants to pass out. Signs of shock. Diaphoretic. Okay, lead us to shock, right? Ischemic chest discomfort. We're not sure. He has chest discomfort. Acute heart failure. What would show us that? Puffy hands and feet. Crackles in the lungs. We don't have any of that right now. Okay, but is he symptomatic? Is it causing him to be unstable or stable? Blood pressure is really our biggest indicator of that, right? Unstable. What do we do for an unstable, fast heart rate? Synchronized cardioversion, right? We need cardioverting, right? Okay, so what do you need to tell him? Or, well, that being said, what do we give if we have time and if patient's blood pressure can handle it? A little sedation, right? Can his blood pressure handle sedation? No. Sedation, morphine, all those things drop the blood pressure. So we can't sedate this guy, but he's coming out of it anyway, so probably not going to phase him too much. Okay, so synchronized cardioversion. So on your monitor, you would pick the defibrillation button, but you would, when you click on it, on this one it's not working, but you would tell it to sync. There's a button that says sync, you would hit the sync button, right? So that way it syncs up and you'll see little dots on those QRSs. It'll sync it up so it doesn't hit in the wrong spot and kill their pulse altogether. So you want to sync it. So you would hit sync. How many, what do we usually cardiovert at? The book says different things, 50 to 100. My thinking and the instructor that I learned under, she's like, hit him with 100, why not just get over with? So I would probably hit him with that. The little tiny little lady, I might hit him with 50. But this 64-year-old man, he's been in this rhythm for an hour. I'm gonna need 100 to probably get him out of it. So I'm gonna sync it up. I'm gonna go low dose 100. I mean, that's high dose on cardioversion. It's low dose if you were defibrillating. We defibrillate at 200. So we're gonna sync him up and we're gonna cardiovert. synchronized cardioversion, we'll say we synchronized it, we turned it to 100, and we tell the patient, okay, you're gonna feel a little bit of a pressure in your chest, you're gonna feel a little bit of a shock. Okay, who's gonna push the button? Whoever we determined to be the button pusher has to clear everybody, right? So let's say we told Gracie, okay, Gracie, you're gonna shock you. So Gracie, what are you gonna tell everybody? Clear. Are you gonna say it loud and you're gonna double check that everyone's clear? You're gonna say this is the way I learned it. They don't say it too much anymore, but we all did the same thing over and over. I'm clear, you're clear, everybody's clear. So you want to say I'm clear, and you say you're clear, and you're looking at everybody to be sure they're clear. Everybody's clear, shocking now, and then you push the shock button. So you want to be sure you don't accidentally shock your team members. They may not be paying attention. They may be worried about bagging up there, or they're looking for the family, or they drop something on the floor. Be sure you're really clear before you push the shock button. So I'm clear, you're clear, everybody's clear, shock delivered. Boom, hit the shock button. Okay, so we've shocked him. What happens after we shock? And we'll look at our rhythm, right? Let me see what's supposed to happen. After we shock. Okay, so we shocked him. This is what his rhythm shows. And then so what is that? Okay, be sure you confirm in 2 leads. Is your patient talking to you and this shows up? It's not really asystole, right? You're not gonna talk in asystole. So it could be that, especially that your ground lead, your bottom one has come off. So double check that all your leads are still on. So when they say check in 2 leads, this is reading lead 2. The rhythm strips that we all look at, that's lead 2. That's the one that's the bottom of the EKG is lead 2. It's the most prominent one. That just means switch to lead 3, which means it'll look from a different direction. So if one of the leads is off, you'll know it. If it's asystole in all the views of the heart, then it's truly asystole. So when they say check in more than 1 lead, they say means switching from lead 2 to lead 3 or lead 1, right? There's 3 views. You can look this way, or this way. So just switch to a different one to be sure asystole in a different lead. Okay. So he's truly asystole and he is no longer talking to us. So what do we do now? Start CPR, right? So you've already decided who's going to do what, right? You're going to have a compressor and you're going to have an airway person, right? So one person's going to get up there and back and the other person's going to start compressions. Okay? How fast do we compress?
100%
Fast, right? So 1 and 2 and 3 and 4 and 5 and 6 and 7 and 8. You're going pretty quick. It feels fast when you're doing it. Has anybody gotten to do CPR yet? But you haven't done CPR. Get in there and do CPR if you can. It's hard because our job is bagging and we really want you to be able to bag, but you need to know how to do CPR as well. I mean, you need to know what it feels like. It's very interesting. Okay, so yes, so you've got 2 people doing CPR and we've got an IV. All right, so what are we going to do now? Okay, which algorithm are we on now? I know cardiac arrest algorithm, right? Okay, so what does cardiac arrest algorithm say? Give oxygen. Okay, we're bagging our patient, right? Start CPR. Bagging our patient, hooked them to the flow meter. We're obviously on the monitor. We already synchronized cardioversion, so we already, we'll pretend we already have these pads on, right? These are our shocking pads. Okay, so asystole PEA side, right? We're in asystole. So are we going to shock them? No, it's not qualified. It's not called for on that side. All right, so good CPR. So what med are we going to give while we're doing good CPR? Epinephrine, right? How much? 1 milligram every 3 to 5 minutes. So somebody's writing down. So if there's only 3 of you in the Thursday group, there's about to be 3 people. The team leader is probably going to have to be the writer, which is fine. You're calling everything, so you're just writing it as you go. You can write on the board over there. So writing down what's happening. Okay, so we tried cardiovert, and this patient went to asystole, so now we're doing asystole algorithm. Okay, so we give IV epi, right, 1 milligram, still doing good, continuous CPR, trying to figure out maybe what's the matter with this guy, right? Most likely, considering he's had chest pain before he even started having a funny rhythm, he potentially had one in his mind, right? Is that what we're thinking? But I will make you go down those H's and T's, right? So what are all the H's and T's that we would be thinking of? Hypovolemia, hypoxia, got 'em, we're bagging them, we feel like we're doing a good job. Might be an option to intubate in case hypoxia is our problem, right? So maybe think of intubation. So thinking of airway stuff, right? Okay, so hypoxia, hypovolemia, what do we do for hypovolemia? Yeah, right, give them a bolus, right? Give them a big push of saline, hang a bag, okay? What else? Hyperkalemia, who's that? Nausea and vomiting for a long time, metabolic alkalosis potentially. Renal failure patients, they tend to be off on their potassium. Patients that take a lot of Lasix, their potassium will be off as well. So that drug list will be helpful. He only takes metoprolol. What is metoprolol? It's beta blocker, right? So it's for the blood pressure, right? His hypertension. So he takes a beta blocker, which is usually good for the heart. So that's not the problem, right? It's probably not getting his potassium off. He doesn't take Lasix. Okay, so thinking of those, what else? Oh yeah, hypothermia. He's warm. Temp was 37 degrees, right? Okay, what are our T's? Does he have that? Not unless we just caused it with our CPR. Probably not there yet. What else? Tamponade, there again, unless we caused it with our CPR. Probably not. He didn't get hit in the chest with anything. Toxins, did he take any drugs? He didn't tell us he did. Doesn't really look like a drug abuser. Do we see signs of tracks? Things like that. Track marks, they'll be on their arms. We see them. Huh?
I understand. And thrombosis.
Thrombosis, right? Coronary or pulmonary, right? So most likely we're thinking coronary because of the complaint of chest pain and the diaphoresis, things like that. So we tried to get a 12 lead, but he was in VTAC part of it, and then now he's in asystole, so the 12 lead won't help us really at this point. So we pending a 12 lead if we get our heart rate back, right? So we're thinking of all those things. So right now, nothing's jumping out at us except maybe coronary thrombosis. So we just need to do really good high quality CPR and see if that heart will respond to us pushing fluid around and hopefully perk back up. Okay. All right. So we've done CPR for 2 minutes. We're going to check a rhythm. This is a good time to switch, and we're looking at our monitor. And our monitor's dead, so it's sad. So looking at the monitor, we're still in asystole. So what are we going to do now? He's in CPR, and we give any more drugs? More epi. Yeah, so it's been 3 to 5 minutes. We can give, how much epi? 1 milligram again, right? We're giving 1 milligram every time of epi. Epi, really short half-life, wears off pretty quick, so that's why we can give it so frequently. 1 milligram is not really too much. Okay, so we've done CPR for a good bit here. And then we do a rhythm check after 2 minutes. And this is what we see. Okay, so you've got a rhythm change. Check for a pulse, right? He does not have a pulse. PEA, right? But electricity is better than nothing. So you're like, yes, maybe we're getting somewhere, right? So what do? We just continue doing good high quality CPR. Keep giving our epi, right? Giving some fluid boluses, maybe he's hypovolemic and maybe that fluid will help. And come to find out, it does. 2 more minutes have gone by, his color's pinking up. Your respiratory, you've got an title on there, and you notice it changes color. What color's good? Yellow, right? So it was purple and now it's coming yellow. So you're like, ooh, my end title's turning yellow. Let's check for a pulse. We get a pulse, and this is what we see on there. Our rhythm, and now we have a pulse. So what do we do from here?
Post-cardiac arrest.
Post-cardiac arrest care. Okay, what does that include?
Maintain your airway.
airway, so probably get him intubated, right? Manage, it says, if we're still bagging, 10 breaths per minute, keep our set 92 to 98, entitle 35 to 45, so put the entitle in line, maybe, this is more EMS related, they do entitle measurement when they do the hospital. Yeah, and then hemodynamics, okay, we wanna get our blood pressure up 90 over at least 60, right? So what are things that can help with the blood pressure? Yeah, vasopressors, yeah, right, so like what? The most common one you're gonna see in this situation is gonna be dopamine. They're gonna throw dopamine in them. It helps perfuse the kidneys too, and the kidneys probably got a little dinged when we were with low blood pressure for so long. So dopamine is probably gonna be your choice for this situation. So yeah, so let's give them some dopamine and obviously fluids, right, they need extra fluids. The fluids are probably stuck in third spacing for a little bit, because CPR is not as effective as the real heart pushing fluid around. Okay, so then we're thinking, okay, we're hopefully grabbing 12 lead at this point, and we might see some elevation somewhere, right? It may look like an NSR in lead 2, but the 1, 2, 3, 4, 5, 6 might show some elevation, might guide us as to, is this truly a heart attack? What else can help us know if our patient's having a heart attack? What else will we do in the midst of all of this? We always grab a 12 lead, labs, grab some labs, right? So you can get some blood out, right? Hopefully they can get, with our CPR, they can pull some blood, or we can do femoral blood gas and get some blood. It's either venous or arterial, and we can get some for us and some for them as well. So we get some blood, we draw some labs, and troponin's high. Troponin, what's our cutoff on troponin? What's a normal troponin? Yeah, it's tiny little numbers like 0.1, 0.01, something like that is normal. So anything above a little tiny number is significant, right? So troponin is specific to heart damage, right? So troponin is going up. The other one that goes up is that they check is CKMB. That's an enzyme that goes up when you have dead tissue potentially, or ischemia or something like that. It can go up even if you had injury. So CKMB, if your patient's a trauma patient and we get a CKMB on them, it could be high as well. So it tells us about injury. Troponin is specific to heart muscle. So if the troponin's up, that specifically tells us we think we have an MI. So we would get a 12 lead, we would get an x-ray, and we would get labs, right? So our labs tell us troponin's high, we think it's cardiac, so we're calling cath lab, right? We're gonna try to get him up to the cath lab to get whatever's blocked unblocked. So what does that mean to you? You need to put them on the vent and get ready to go to the cath lab. So you're like, hello, can someone cover ER for me? I'm getting ready to go to the cath lab. You're gonna be in the cath lab for a good 2 to 3 hours. So yeah, so somebody else is gonna have to cover all your stuff while you're gone. Or somebody else is going to the cath lab and you're covering your stuff and their stuff. So, okay, so if our patient didn't wake up, let's say he went to the cath lab and he still didn't really wake up afterwards, we would be looking at that temperature management, right? Cooling down for a little while, which is very common now. What temperature are we cooling him down to? 32 to 36, okay? Which normal is 37, so it's really not that cold on the high side of that. Okay, so got our 12 lead, went to the cath lab, came back from the cath lab, he's not following commands, he's not really awake. So that's where we're doing our temperature management protocol and also trying to get an EEG order for brain activity. Whenever your patient goes down and you do CPR, it does not push blood. It's about 30% of what you would normally be doing on your own. So even good, high quality CPR, our ejection fraction is about 30% of our normal. So you're just not perfusing well. So any amount of time that you're down, even if we're doing good quality CPR, you have substantial increase in risk of anoxic brain injury, right? So anoxic brain injury means the brain was without oxygen and now it's not working anymore. So our EEG would help us with that, right? All right. Okay, you want to do another one? All right, let's do all the steps. Let's walk over to our location area. Do you want to go through the ribbons real quick on here so you know what they look like?
Yes.
Okay. This one is, well, what is this one? What y'all think? V-fit, right? We would even call it a coarse V-fit, right? It's kind of big. Okay, so yeah, so ventricular fibrillation, right? V-fit, what do we do for V-fit? V-fit, V-fit, and also V-fit, right? So we need to defibrillate, and we will not sink it, and then how many joules per volt? 200 joules. Okay, so there's V-fit. It takes me a minute to find them on here. I thought that had a, see, you see how tiny these letters are? Even with my glasses on, sorry. Okay, and this is the one we just saw. What is that? V-tag. I don't know what this one is. Can't read it. Idioventricular. Okay, so that's idioventricular. It's a little higher right there. We normally would see at 50, but idioventricular, dying heart, right? It's almost like the agonal. This is what you see at the end. So it would be, this would be, you would be doing chronic CPR. They would be pulses for that. What is that one? A flutter, right? Got the sawtooth. About a 3-to-1/2-to-1 conduction ratio, right? 3 bumps to 1 QRS or 2 bumps to 1 QRS. Okay, what's that one? AFib, right? I'll see this all the time. It's not a very fast AFib, it could be faster, right? so skinny and fast, supraventricular, we don't know where it's coming from, because it's going so fast, we can't even tell if there's a P wave or not. Could be fast and good, we don't know. So SVT, supraventricular, somewhere from the top, because it's skinny QRS, we can't tell where. It usually goes fast. PSVT, what's the difference between SVT and PSVT? What does PSVT stand for? Paroxysmal, meaning it just comes out of nowhere. And that is a common form of it. The SVT, it can be related to a heart attack or something else, but at PSVT, patients will have PSVT where they just go into this really skinny, fast rhythm, and then they'll get out of it, and then they'll come back into it. My mother-in-law has it, my brother-in-law had it. It's sometimes hereditary. What they do for it now, when they come into the ER, if they're symptomatic, they then shock it, right, or defibrillate, right? Not defibrillate, cardiovert. We would cardiovert that. Over time, if they have it coming back and coming back, they can take medicine for it to settle down the heart, some of those calcium or sodium channel blockers, or they can do ablation. They'll go in and ablate that heart. They'll kind of cut those little, trying to cut that weird aberrant pathway. For some reason, they just go into this weird. They don't have heart problems. They just, for some reason, the heart wants to take a different path when it's trying to send a message. So PSVT, if it was PSVT, they're showing PSVT is a little different. Look, it's 300 on this one. The PVC. And are they multifocal or unifocal? Their underlying rhythm is PACs too, right? That one came early. PVC, normal, PVC, normal, fast. So I was wondering if you're pacing. You can't tell what it says. You can't tell what this one says either. We've got PQRC, and then just, I think it's sinus arrest probably. Yeah, it's sinus arrest. Okay, so it just takes a long pause, but the other underlying rhythm, everything is normal. And there's no like drop of the P wave or anything like that where you would think it was a block. It's just for some reason they just have these pauses. Exactly.
Science tap.
PQRST, PQRST, PQRST. It's easy to see on paper. When you're looking on paper, you know, it's stopped right there. When it's going across the monitor, and this is how you're seeing it in the hospital all the time, it's a little different. You can't like sit and measure those things either. You're like, I think this is sinus tap. So it's a little different as it's running across the monitor than it is. So real life is a little bit different than looking at it on the 12 lead. Okay, so yeah, so sinus tap, we're above 100 beats per minute. So what are causes of sinus tach usually?
Pain.
Angular, fever, infection, or septic patients will be tach usually. Yeah, something, even hypovolemia to make up the difference, it'll go faster. So quite a few things that are very treatable, right? So sinus tach, we don't usually do anything for them besides just treat the underlying problem, right? And this is what our heart rate 70, PQRS like looks like helical, right, big to little, or it's actually flipping the axis. I don't know what that's called. It's called turning torsides to points. Torsides is what most people call it. It means turning of the points, turning of the axis. So it's flipping where it's trying to send a message from. What's the treatment for that? Magnesium. They get this heart rhythm from hypomagnesemia. So who's going to have that? Who's low on magnesium? Alcoholics, homeless people, people who are nutritional deficit, you're going to see just torsides. Or if they're just electrolytes are just really out of balance, sometimes we'll see torsides. So in that situation, when you see that, you need a hang mag, right? You need to give them some magnesium. Okay, I don't think there's any blocks on here that I can find. This is an interesting one, and we don't see it very often. It's called Wolf Parkinson's White. It's usually way faster than that. I don't know why it didn't default to a really fast rate. It's called WPW, and it's generally patients come in, but I've seen it with young people. It is a congenital heart condition where they just have a aberrant pathway that just, for some reason, they have this weird pathway. It doesn't follow the normal path of electricity going through the heart, but it's a certain pathway that usually they have to have an ablation for it. It has a certain look, and on that, you can see, they call it an incomplete bundle branch. You can see a little bump on the left side of that QRS. That's a little bundle branch block, and it has a certain look. Another name for it, sometimes that little bump is bigger, so it goes like that, and a little bump next to it, and they call that a saddle block. So it looks kind of like a saddle on that left side of the QRS. So occasionally you'll see that. There again, we can slow it down, we can see what it looks like. It's usually going so fast you can't really tell. But if you have a young person that comes in, if they can slow this down, then they will, it looks a certain way on the EKG. So they're gonna have to go to cath lab or so. They probably won't even do it that day. They'll slow it down, put them on medicine, and then they'll do an ablation for them. That's really the only treatment right now for it. But yeah, they will just boom, go into that phase. Okay, let's see. All right, here's what I was gonna do. Okay, who wants to be our team leader? Anybody got to take a turn? All right, David's a team leader. Who's on your team, David? Pick 3 other people.
I'll make the top under.
Okay. Come on. All right, so y'all are the team members, so you go ahead and pretend like this is the ER, even though it's really saying that you're at someone's house. You're at their house/ER. So go ahead and decide. We know this patient's coming through the doors in a minute, so go ahead and decide what your team members are going to do.
Airway. Is that what I'm assigning?
So that when the patient arrives, they know what their job is.
Airway, compressions, IV, access.
Okay.
And I guess I'll be reporter as well.
Okay, team leader and reporter, all right, and you guys can also just call out that he has signed roles for if the patient's in arrest, but before the patient goes into arrest, what would you be doing as well? You just call out what you want, which would be what? Right, okay, what else? What could y'all be doing?
Setting up the
Setting up IV step, okay, what could you do?
setting up the camping bed.
You could, but we needed to do some other things first. Pulse ox and what's that on his arm? Blood pressure, yes. So pulse ox and blood pressure. So, and the nurses know this more than we do because they do it all the time, but we don't. So if we were part of the team, we would need to be like, I'll do blood pressure. So if you're doing those things, and you never know, if you go to a code up on the 6th floor, those people don't know how to do a code. So you will be doing a lot of work. You'll be like, yeah, okay, I'll take a blood pressure. Yeah, I can do this. Because they are going to be flipping out. I've gone to them. I mean, back in the day, 6th floor was rehab. Those are rehab nurses. They don't do codes. and this patient coded in the cafeteria, and they had no clue. They did have a crash cart, that was all we had, was the crash cart. We didn't have an oxygen tank, we were just bagging with air, it was horrible, and I mean, like, I was up there, so I was the person who sort of knew more what to do, and so I don't feel qualified to run a code, but I was better than anyone else, because the nurse who actually had the patient was crying, and I'm like, oh my gosh, I was like, get over yourself and get over here. I was like, okay, somebody needs to grab a blood pressure cuff, let's get them on the monitor, okay, EMB bag, somebody go get a tank, they're in the satellite station over there by the elevator, you know where that is, go get a tank for me. So we could bag, and then I'm like, somebody else do CPR, okay, do they have an IV, okay, what drugs do you give? And then like, finally the charge nurse was like, give epi, okay, so grab some epi, and by this time the doctor had come up. But this is in the cafeteria, so there's people eating all around, with little people, and they were all freaking out. It was horrendous. We finally were getting, they finally get a bed and we get to roll them away, but it was just a cluster of so many levels. But, so you may have to sort of know what you're doing, because you may be the only person who does. So, okay, so yes, you would call out that you're doing those things. All right. All right. Your ambulance has been dispatched to help an elderly man having chest pain. There's also another EMS that's arriving that knows more stuff. They call it BLS engine, I don't know what that means. Oh, ALS ambulance. Okay, you arrive to find the firefighters placing a non-rebreathing oxygen mask on the patient. So they've already done that, and they're fixing to come to you in the ER. Okay, so he's sitting with his back against the wall, against the chair, no, against the bed. I'm trying to make this into an ER scene. He's alert and he's talking. He was at the bank and he started feeling bad. So he went home and the EMS went there and picked him up, and they're just a basic EMS, so they really don't know how to do anything besides putting him on a non-rebreather. So he's rolling into you. Oh, this one's complicated. All right. What would you like to do? He's rolling through the door screen. All he has on is a non-rebreather.
And he's still awake, talking?
He's still awake and talking right now.
Vitals, attach your beats.
Touch your monitor, okay. Hold on. What else would you like to get?
ECG, probably?
You don't have it yet.
Don't have it yet, okay.
Okay, you've got the monitor on, and this is what the monitor shows. What else would you like to get? Would you like some more information on your patient?
Yes.
Okay, he said, I feel like my chest is heavy and I feel like I'm gonna throw up. He was waiting in line at the bank. It started abruptly while he was waiting in line. What other vital signs would you like? This is his heart rate and his monitor. Your blood pressure's 86/48. Respiratory rate is 18. Not labor, and his stats 100 on the pulse ox. This is what your EKG is showing. Come to find out. No, you'll know. Keep going. This is what your EKG is showing.
Need IV fluids?
Okay, did you have someone start an IV?
No, you started IV. Okay, so I got that. Got his blood pressure. I take him off the non-rebreather. I'm on nasal cannula.
Okay, good.
And
What does our monitor show?
bradycardia.
Brain volume, right, so it sounds like
Atropine.
Atripine's a good choice. How much would you like to give? Yeah, they made it easy. They just changed that. The last go round and find some of your paperwork says 0.5 milligrams. They changed it, so epi's 1 milligram, atropine is 1 milligram, so it's easy. You can only give how many doses of atropine? to 3 milligrams. So you can only give 3 doses of atropine. Okay, so you give him some atropine. Come to find out, this patient has had a heart transplant a couple of years ago. So, this is a side note, y'all wouldn't know this, but it says atropine does not work if the heart is what they call denervated. Yeah, denervation. So atropine doesn't work on patients with a heart transplant. So FYI, atropine actually doesn't work on a lot of heart things. So we give atropine in case it works, but it often does not work. It doesn't work on any kind of wide block, 2nd degree or 3rd degree. It's not going to work on those. This is not actually a great drug, but we're going to give it a shot and see if it works. But in this situation, it does not work. And his blood pressure is dropping, and he's feeling kind of hecky. What is our next choice? That's the atropine. So looking at your Brady strip, what's that?
Dopamine infusion, or transcutaneous spacing, and or dopamine or caffeine infusion.
Okay, so we've got an IV, right? We tried some atropine, it didn't really work. Okay, so you could throw some epi at it, see if that'll speed things up. All the meanwhile, getting ready to do transcutaneous pacing. So where are your pacing pads? Over there. Okay, so put the pacer on and give him some epi. And then you look over and your patient says, "Whoa, I don't feel good." And then that's all you hear from him, and he passes out. And you look at the monitor, and this is what you see.
Defib. So we need to get ready to defibrillate.
Okay, and what else? You already got the pads on, so that'll be easy fix, right? So what are you gonna defibrillate at, and who's gonna do it? And what is the rest of your team doing?
Jocelyn can defibrillate at 200 volts.
Okay.
Omnipod managing airway. And Mira. What else? Can we give?
You can actually already, so your defibrillator has to charge for a minute? So what can we do in the meantime? Yeah, okay, so whoever was assigned CPR. Oh, that was Jocelyn. Okay, so maybe now you're gonna have to do your shock thing.
Okay.
Okay, so you're getting ready to shock, Jocelyn's doing compressions, Monica's doing what? Airway, okay, so you have the ambu bag and at the head of the bed. Can you get up there? Go ahead and get up there so you can pretend. Put that head down flat. There's an ambu bag right there, right there. Okay, you can move the van out, we're not needing it right now. Or everyone's driving on the other street, you're like stepping over things, and there's a curtain right here because there's someone else there. Okay, so pretend like you're bagging up there on the go, and be sure you know how to bag. Alright, okay, Jocelyn, do some compressions. Would you need a stool, you know?
Okay.
Get on the bed. No, just show me how you're doing compressions. Okay, move your hand over a little bit more. Toward the air. Yeah, right there, right in the middle. Right, and you're pushing down hard and fast, right? 1 and 2 and 3 and 4. It's a little practice, because if you have to do it, you need to remember how to do it. You haven't done it in a long time, right? Since CPR class, a year ago, more than a year ago. Okay. Are you counting out loud?
1 and 2.
Doing good quality CPR. Tamara, what are you doing?
Checking to see the.
Okay, so it's charging. Okay, so while it's charging, can she do CPR? Yes, right. Okay, so but now it's charged. Okay, so oops, it's charged. Okay, so what are you gonna do?
Say clear. Well, no.
Say it, do it. I know it's awkward, but hey, remember, muscle memory. If you've done it before, you'll be more likely to do it correctly when your head's not thinking straight.
Okay.
Are you clear?
Clear.
I'm clear. You cleared yourself. Yeah, everybody else is clear. Okay, shock. Now say, what do you say? Shock delivered. I'm doing shock. Shock delivered. Good. Okay. Everybody's clear? Okay, so what do I need to do now, Dave?
Do we just shock them?
Yeah, we just shocked him.
Start CPR, check for a pulse, continue bagging.
Okay, start CPR, continue bagging, keep doing CPR, and what med, during CPR time, we're gonna give a med, right? Okay, epi,
Push epi.
epi's pushed, good. Okay, so we can get our epi out, have it, no? Yeah. So if you give a med, grab it and put it out, that way you can, the recorder can remember what meds was given, and you would be writing down what time. Just pretend that. Okay, all right, so we're doing CPR, good quality, high quality CPR, right? Which means we are trying, if we get them back, if we've done good quality CPR, they'll hopefully stay back. Otherwise, if we did not do good quality CPR, which basically means we didn't pump that fluid around enough to fill the heart, they won't stay good. They'll go back and be tachycardia. But right now, they're still in it, so they're still in this rhythm, well, we're seeing CPR motions on our monitor in real life, but, okay, so it's been 2 minutes. What would you like to do?
Check the rhythm again.
The rhythm?
Same thing.
Same.
And during shock.
For everybody?
Oh, it was charging the whole time.
Oh, okay, sorry, oh, it's charging, okay, so do CPR on charging. Okay, charge?
Okay, I'm clear, everybody's clear. Shopping.
Okay, shot delivered, okay, what job will you do?
Okay, resume CPR, check for a pulse, start bagging.
Okay, so we've done 2 minutes of CPR, would you like to trade them out?
Yes.
Okay, so at a rhythm check, that's a good time to trade. So either airway can go to CPR and CPR can go to airway, or somebody else can jump on CPR and airway can stay the same, whatever y'all wanna do. You can do it from that side. You can do CPR from any side. Okay, so she can stay airway, you can do CPR, so Jocelyn, you'll take over IV. Okay, so during our good CPR, good high quality CPR, because we traded out, so if the nurse ready, she's fresh. Then what med will we giving out?
Amiodarone.
Triamiodarone.
Or Vicodin. This.
That's amio.
Yeah.
Okay, how much would you like to give?
300 milligrams versus.
Okay.
That'll be. Did y'all switch combinations?
Yeah,
Okay,
so
so
we
Jocelyn. 300 milligrams amiodarone.
given. Okay, so you would say amiodarone given, 300 milligrams. So that you can write it down. This is what they talk about in all the ACLS stuff is communication, right? You say what you want and they say back to you what they did. That way everybody is on the same page. And you will see, y'all seen codes? They're a huge mess sometimes, right? People aren't telling everybody what's happening. People are going crazy. The person in charge of the code, the doctor, whoever's writing the code, sets the tone for the whole entire code. If they don't, and they are crazy, then you, as the respiratory, you've been in a lot of codes by this time, you know how it should look. You and the nurses have to set the tone. And you have to be like, yeah, let's go get a bag. Okay, did you get that one? Okay, I'm gonna be bagging. You can settle the room down. And I've seen it happen a lot of times where the ear docs are notoriously they're just out there. You're like, what is that? What's wrong with you? But they'll be like, why is that a 2-band? They love playing respiratory. Is your ET 2-band? Well, yes, it's in. I can see the chest, right? I'm in charge of it. And, well, did it get displaced? I bet it's displaced. Y'all are always losing the tube. They literally will holler at you, and you're like, we have never even lost a tube. You'd be like, whatever, are you crazy? But yes, you can say, yes, my tube is in. I'm getting good bilateral breath sounds. I'm getting good chest rise. Your tone can help settle the tone of the room, so just keep that in mind. Okay, so you're still doing good CPR. You traded out. Let's see. Then 2 minutes of good high quality CPR. Okay, what's the first thing you do with the rhythm change?
Check for holes.
He does have a pulse. And Annika agrees because she has her end title up there, and it jumped up from 20 while ago to now 40 something, right? Or it turned yellow if you just have a little purple yellow. So you're like, yes, okay, we got a pulse. All right, we're in AFib, which is not great, and we might need to treat the AFib, but for right now, we're just glad we got something back, right? Okay, so we used to say, whatever got them back, we want to hang. So if we had given amiodarone 300, and that got them at least to this, AFib's better than nothing for sure, right? And that's full. So if we got them back with amiodarone, we want to hang an amiodarone drip. So for some reason, that's that antidysrhythmic is helping this patient. So hang an amiodarone drip and do post-resuscitation care, right? Which includes what?
They're still breathing. Not good.
He's really not breathing on his own.
Okay, so we need to keep that,
Yeah, or maybe what at this point.
or things to
Yeah, let's get intubated, okay? Getting intubated, what else? We hung in the other drip. Try to keep him stable.
check his blood pressure, see how we're doing on that.
Okay, blood pressure's come up, it's 80/40. Better than no blood pressure.
Yeah. Now we can go to 12 weeks.
Yeah, go to 12 lead. It's showing AFib, right now, but also a little bit of SC elevation. So what are y'all thinking?
And, no.
Maybe an MI, correct? That's unfortunate. This is a new heart, right? He just had a heart transplant 2 years ago. Whoa, he's having an MI. Potentially could be something else. It could be lots of things, but, yeah, so there again, at this point, it's okay to say seek expert consultation for the heart problems that this man might be having. Okay, so we got him back. What else? What else is part of our post care? Or seek expert consultation on the heart. We're glad to have AFib. We're not going to treat it right now. He's got a pulse a bit. Blood pressure's not great. We're giving him amiodarone to keep him from going back into VFib and a bunch of fluids. Right. Let's get some normal saline going too. Try to get that blood pressure up. Okay. What else? I'm intubated. Is he waking up?
No.
He's not waking up. He's not responding to commands or anything right now. So what would we be thinking?
What to do or what? Targeted temperature management.
Okay, let's cool him down.
CT scan of the brain.
Right, yeah, so you may be going to CAT scan with this somewhat unstable. A lot of times they will order the CAT scan, they won't go right away. They'll take them up to ICU to get them stabilized before they do the CAT scan. But yeah, we're getting it ordered. We're getting what else ordered?
EEG.
EEG. Let's check out that brain activity and see what that looks like. Okay, so neurologically, we're looking at that side of it. Also, seeking expert consultation on the heart side. He might be going to cath lab as well. We're not sure what they're going to decide on that part of it. Good. Okay. How'd that feel?
Pretty bad.
Okay, pretty bad how? Like, what do you feel like you could have done different?
Well, like know everything, but like when you're assigning roles and everything, knowing what everybody's supposed to be doing, and it's better like recognizing where you are along the line.
Yeah.
So
And part of that's just getting more comfortable with your algorithm, right? In real life, you don't have time to look at your paper. But that's, this is not real life yet. We're going a little slower. But when you do your checkoff next week, I'll expect that you'll be going pretty quick. So you'll know what to do next. So you'll be kind of running the show, whoever the team leader is, and I'll just be giving you information as to what is happening. Does that help? Does that help doing it? Almost always doing it helps, right? All right. Who else wants to be in charge? We'll do one more. Then you're on your own next week. You can stay and practice looking at the rhythms on here so you can recognize them. I think that's pretty helpful. Oh, yes, so we're going.
Yeah, I was looking at that. I'd like to go Tuesday.
You would, and Chris, you can go Tuesday. people who would like to go Tuesday? I'll just leave volunteers. Unless, no people volunteer and then
I'll go Tuesday.
is that?
Corbin.
Corbin? Maybe Gracie, Corbin, and Krista. Okay, that leaves the rest of you to Thursday.
And we like take turns doing everything, right? Okay.
Yeah. Okay, so Tuesday we'll come in at, let's come in at 8:45 to get our test done so that we can get through ACLS by 12. It takes about 2 hours to run 4 people through it. All right, who wants to practice one more? Scenario. You don't want to practice a scenario. You're always going on Tuesday? Yeah. Okay, so just remember, you're gonna have, because of the way ACLS works, I have to do a mega code where your patient is gonna have about 3 rhythms. They are always gonna go in pulse, speed, tach, or refib, because that's part of every scenario that you have to know that algorithm. So, you know you're going there, so remember the algorithm. All right.
It just might be pretty slow.
Okay, you're a healthcare provider, caring for a patient who is admitted for chest pain and ruling out myocardial infarction. He was diagnosed with stable angina 10 years ago, but over the past few months, his pain has been
Can you repeat that? Stable
stable angina.
Okay.
So he's got chest pain.
I just didn't hear you.
You're like, diagnosed with stable angina 10 years ago, but over the past few months, his pain has been increasing in duration and intensity. So he's had some heart trouble, but it's been a while. Okay, so you are the nurse coming in. It's change of shift right now. Don't tell them their roles yet because you're not in the ER, you're on the floor. Let me read this real quick. Okay, so you're in the patient's room, you're talking to the patient and his son. He says he's not having chest pain right now, this is his rhythm on the monitor. His vitals are good, he's just on a 2-liter nasal cannula, everything looks good. You leave the room, you go to look at your other patient, and the son calls you back and says, hey, my dad is complaining of chest pain, he doesn't look good, can you come check on him? He's freaking out. So you glance up at the monitor, and this is what you see. On the monitor, and you look in at your patient, and he's very diaphoretic and holding on to his chest. His heart rate's really fast. What else would you like? What would you like? Carissa, David, and Gracie come with you, because they're also, they know this is a rapid response probably. So what would you like for them to do?
He's already hooked up though, right?
He's hooked up to the monitor, he's got 2 liters on. What else, what other vital signs would you like?
His blood pressure.
Okay, would you like them to do?
First, I need his blood pressure. Check his O2. So that's
Okay, blood pressure, pulse ox on, okay,
he needs to be shocked. He's in SVT, right?
Okay, his blood pressure is 156/92, his stats 93, respiratory is about 22. Yeah, okay, so, we could shock him, but
Yeah.
is he having,
No, but he seems okay.
right,
Is he awake?
he's awake and he's talking to you, and he just says, my chest is hurting and going really fast. So what would you like to do if he's stable or unstable? That's our question. Blood pressure 156/92. He's awake and alert, blood pressure is pretty good. Okay, so, but we can't leave him here, right?
No.
So what would we like to do?
Maybe. I mean, because I started on like something, but like I started on, and they says that in the other room that could I do like a drip in the other room, or should I do like therapy?
Yeah, the drip would be what you would give if it's not a code. So yeah, you can start in my MEO room, or there's another drug that we usually use first.
Or. How do you say that?
Adenosine?
Adenosine?
Adenosine. So yeah, so you could give him some adenosine, try to slow him down. So he's not unstable yet, but we're headed there, so yeah, let's try some adenosine. How much would you like to give, and who would you like to give?
6 milligrams. And I'll write it down.
Okay, so Danny, what do you say back to Corbin?
6 milligrams, do it.
Okay, right, yeah, and it's over there somewhere. It says adenosine. Adenosine? Yeah, that's it.
I don't know,
There it
see
is.
it,
Oh,
you
look
can-
at that. Okay, so yeah, so now we've got, because we already have an IV, because we've done it. Okay. Adenosine is given, all right. Okay, 6 milligrams of adenosine is in. What is adenosine? Or what would we expect to see with adenosine?
It's harder to come out.
It's gonna stop for a second and then come back. Do you need to tell him something?
Yeah, so you're gonna.
Yeah. Your heart is gonna stop and we hope you come back, we don't know. No, you're just gonna say, you're gonna feel really funny for a minute. We're gonna stop your heart momentarily. And if it doesn't come back, we're gonna do some CPR, is that okay? Yeah, just say you're gonna feel really, it makes them feel funny, and they will, they call it tanking. They will be like, oh, they're gonna crump, they're gonna feel really bad, and they get real flushed with it.
Does it work pretty quick?
It works really fast, yes. If it's gonna work, you'll know right away. It will literally slow down to like nothing and then come back. And usually, in my experience, 6 milligrams might slow them down to like, from 200 to like 150. And so you're like, okay, we slow down and then boom, they're back to 200. So if that happens, we're still stable. So 6 was given, we didn't really get much of a response. What would you like to do now?
Do I have to wait a certain amount of time?
Not really, it's a really short half-life.
So could I give them 12
Yeah,
milligrams?
yeah, and generally it takes 12 to do any good.
And then,
12 milligrams, adenosine.
got it.
Okay, 12 milligrams of adenosine has been given. Some reasons why adenosine wouldn't work. You drank 3 cups of coffee this morning. Caffeine blocks adenosine. So, really, you're like, did you drink coffee? It's not
Stop it.
You're on the cardiac floor.
Yeah.
Gracious. And his son brought him some coffee from Starbucks. So adenosine does, there's quite a few reasons adenosine doesn't work. So it doesn't work on him. And now he's starting to complain of feeling really bad because he's been in this really fast rhythm for about 20 minutes now. So what's going to start happening? His blood pressure gonna drop, right? So remember that squeeze, it's going too fast, it doesn't have time to fill, so cardiac output's dropping. So now our cardiac output and blood pressure are dropping, and he says, I feel like I'm gonna pass out. He passes out, so now we've become unstable. So what do we do with that?
Well, we do a shoulder, but do I need to tell me back, CPR?
He's passed out, but he's still breathing.
But he's breathing.
And he still has a pulse, right? You would have someone check for a pulse, right? Does he have a pulse? Yeah, he's still got a pulse, okay?
So could we shop him out since he's technically unstable, right?
Yeah, is it shock or what do we call it if we don't? If they have a pulse, what do we call it?
Oh, see.
Yeah, synchronized cardioversion, right, okay. So we want to sync him up and cardiovert, okay? So who would you like to do that? What would you like?
You can sync it and it's 100, right?
Okay, so 100, okay. So we're gonna put those pads on, right?
Yes.
Got the pads on him? Okay. Okay, Gracie, you're pushing the button, even though it's only 100, enough to knock your pants off, right?
Everybody clear?
Loudly, everyone clear.
Everyone clear.
Okay.
Shock delivered.
You didn't tell him anything, and he's like, what the hell? What happened to me? I don't even know what you're
He's
doing.
like, no, yeah.
Oh, I forgot to tell you we were gonna show you. Well, he was out of it, but if they're awake, tell them, you're gonna feel, we're gonna just give you a little shot. If their blood pressure's good, you could give them some sedation. A little bit of dipropam goes a long way, so if you had it, you get it. And his blood pressure was fairly good at first, but then it dropped, so. I've never seen them be able to give sedation. They do them in a cath lab sometimes, but on the floors, their blood pressure's always too low to give them sedation, so these people are just, I don't understand. Okay, so we give him a little cardio version. We think it's all good. And then he passes out completely, and this is what we see on the monitor. Got a rhythm change, so what do you do? Okay. So what are you gonna do?
Check for pulse.
Nanopulse.
Has no pulse. Start CPR or
Greg?
Gracie start CPR. And then to shock him deep in.
Okay, so would you like Carissa to do that?
Carissa, yes, we get it ready.
Okay, we already got the pads on, so that's easy. So what do you want to be sure you do on your monitor?
Just charge it, right?
Yeah, charge it, but to what? 200, and what we were previously doing, synchronized cardioversion, right? Change it to not, right, to defibrillate, not sync. So be sure you switch it off, not sync, and.
Doing some good quality CPR with you guys.
Good, I see you are. Okay, so charging, she can do CPR, everybody clear? You can say that very loud. Louder, clear, everybody clear? And then just say, point out people, David, are you clear? Okay, now what are you gonna do? Shock delivered, okay, what do you want us to do now?
Continue the CPR and guide me to check for a pulse.
There's only a pulse with the CPR, so this is what I'm already showing, so we're doing good, high quality CPR.
Yeah.
Okay, so while we're doing good high quality CPR, what would we do now?
He doesn't have a pulse still. I'll give that me.
We're
Yeah.
doing CPR, so no.
Give that me.
Give that, okay, how much would you like to give?
1 number.
Who would you like to do that?
Chris.
Chris is doing all this stuff.
Sorry, Chris.
You just got a small team, that's all you got to do. Okay, so what do you say, Chris?
1 milligram of every
Do you need to grab it over there?
I was looking for
Yeah,
it.
I don't know where it is.
Oh,
It's in the drawer. Good, high quality CPR, get some epi. And no, it goes a little bit, right? So also, we're talking and we're getting history and we're figuring out what is wrong. Okay, he's had a history of angina. So H's and T's, tell me about your H's and T's.
Hypovolemia.
Got my lead going, and he's had one going, so, I mean, we might be a little low right now, but probably wasn't the original problem, but yeah, what else? What are the other H's? Okay, David, how do you feel like you're bagging? You getting chest rise? I'm kidding. Huh?
looks great over here.
Are you bagging well, David? Are we getting a good chest rise?
David,
I don't know.
sealed properly?
Greg, is that where you go?
Okay.
Okay, so Gracie, are you giving him a chance to, give those breaths?
Probably not.
Okay, so this is where book ACLS, real life ACLS, book ACLS says 30 to 2. You would be counting and he would be squeezing
We
his
just
breath into the chain.
continuously back.
And what in real life, they just continue.
They're like back faster, I'm like, okay.
You're literally, they're just pushing and you're just trying to squeeze the breath in whenever you can because you're like,
No,
when they
yeah,
push
Dr.
down
Fred,
and
he
you're,
was like, yeah, he's like, just keep back, and I was like, okay.
because it's probably not going in very
Yeah.
well because they're going 100 beats per minute. So that's where I'm like, I do think book probably makes more sense that you take a break and let us get some breath in until you have an advanced airway, and then you can control it a little bit better. So at some point we would do advanced airway, we're not there yet, but you feel like your bagging is good, they're bagging easily, good, okay. All right, so that's hypoxemia, what else? And hypovolemia, we got IV going already. He's in the hospital, he's not cold.
Toxins, I don't think he's drug user. Tension pneumo, unless we gave him more.
Unless we gave him one now, but it wouldn't show up yet, so.
Cardiac clot.
Huh?
Clot.
So, not tamponade, so we're down to thrombosis, right?
Yeah.
Thrombosis, so either PE or cardiac, we're thinking cardiac, right? He's complaining of chest pain, he's had angina for 10 years. All right, so we've called cardiology by this point, right? So we've called them to come check on this patient because it's their procedure, but they're not here yet, so, so we're still doing our code. Okay, so we're pretty sure he needs to go to the cath lab at some point, but we gotta get him alive enough to go to the cath lab. Okay, so it's been 2 minutes, we've given our epi and pushed it around, been 2 minutes. We're gonna do a rhythm check, and what else?
That was.
Oh,
He's dead.
I think I have a little chart thing over here.
No, is that what that was?
Uh-huh.
I thought it was like that.
It won't let me do circular. Okay, so we do a rhythm check, and what else is a good time?
Switch.
Tracy like, yes, I'm so tired. Yeah, so you would switch people doing CPR, and our rhythm,
I can back.
and our rhythm still shows this rhythm.
It's a shock again.
Okay, I understand that. Everybody clear? You gotta give them a little more warning. I'm getting ready to shout, everyone's clear, all clear, so a couple of calls. They may not hear you, it's loud in there, right? You gotta be really loud to shock someone. If you've ever seen somebody shocked, it's horrible. I mean, it knocks them flat on the ground, it's awful. I've only seen it one time, and I'm like, oh. These little, that laugh a little bit. Remember, you only have 3 people in here, so if you knock one of them out, it's just 2 of you. You as the shocker is gonna have to do all of it. All right, so we shocked and we're back to high quality CPR. High quality CPR. I could check it if my other thing would work. Because you can actually see, you can put the CPR mode on, you can actually see if you're going down far enough. But it's not working. Just gonna have to get today. Okay, so in 2 minutes, and you, Gracie says, hey.
I see the.
Uh-huh, what do you see, Gracie?
I see it, the entitled in yellow. Yes.
Yes, we have.
Yay! Well, things not changing, I don't know why.
Is he awake?
I don't think he's awake.
I'll shut up.
It's not a way, so who's bagging?
So,
And Gracie was bagging, so what would you like to do now?
Intubate.
Okay.
Fluids, like a lot of IV. I don't know, everybody might be pretty good in there, so.
Yeah, so he's got some fluids,
Give me this stretching.
do a full 12 lead at this point.
Yes.
Okay, so you got a 12 lead, what else would you like to get?
Blood pressure, check blood pressure.
Okay, blood pressure,
Get labs.
Blood pressure's 110 over 80. You grab some labs, yeah, troponins high, CKD is high.
So call cath lab maybe, and if he's not awake, then do temperature management.
Okay.
Somebody else comes over.
Yeah, but, okay, so temperature management though, we wanna cool them down to what temp?
32 to 36.
And how do we do that? How do you cool your patient?
Cooling blankets.
Yeah, they usually put a cooling blanket on, right? Now, if they come into the ER and they're really hot, like if they have heat stroke, they'll do a cooling blanket, but they also do ice packs. Put ice packs under the arms and on the groin, and that will help to cool them down faster too.
Yeah, needed.
Show you why. Yeah, that's all I got.
Okay, good job. Okay, so I feel more comfortable.
Yeah, just a little.
The more you do
I was
it,
thinking it
the
was